Thank you so much. Thank you, Dr. Bhaduri, for putting up a very exciting program. When I saw the topic, I couldn't figure out, it reminded me of Star Trek, to boldly go where no one has gone before, and precision oncology. But I think precision oncology, there's a lot to be said about it. Most of our patients, I would say 98% of our patients will not have access to it. So I think I'm going to talk to you about trends in GI and HPB oncology today. I have no conflicts of interest. So globally, I think what we are seeing, not only in GI, but in other cancers as well, that infection-related cancers like, especially in Asia, stomach is going down, but lifestyle-related cancers like colorectal cancer is going up. Similarly, cervical cancer is going down, breast cancer is going up, the incidence is going up as well. So I'll just give you a snapshot or a bird's eye view of various cancers, GI cancers where the data is actually practice changing for you when you go to clinic for Monday. Total neoadjuvant therapy, I think there's a lot to be said for TNT in rectal cancers. 25 to 30% of our patients do develop distant metastasis with locally advanced or early T3, T4 node positive rectal cancers. And we know that half of our patients actually do not end up getting systemic treatment, and we know that systemic adjuvant treatment does lead to a survival benefit. So the thought process was, why not we bring this forward before neoadjuvant radiotherapy or after chemoradiation? And these are the three pivotal trials, actually, the Rapido trial, Prodige, and Stella, where they have looked at giving radiation followed by chemo or chemo followed by radiation. There are a lot of questions which remain about total neoadjuvant therapy, which sequence you should do first, whether you should give short course radiation, whether you should give long course radiation, what chemotherapy you should give, because all the trials have used different chemotherapy. Some have used Folfox, Capox, or Folfoxiri or FOLFIRINOX. So, but these are the key studies which actually showed that the 3-year invasive disease-free survival or survival without metastasis did get better by 7 to 8% in all of these studies. And in Stella trial, there was a survival benefit as well for the experimental arm, which is short course radiotherapy followed by capecitabine oxaliplatin. Interpreting these trials, these populations were highly selected. So should we only give it to patients who are younger? The median age was between 53 and 62. And we know that the median age for rectal cancer is about 70. There is a risk of overtreatment. None of these patients were offered the watch and wait strategy. There is no long-term survival or toxicity reported. So before we make it standard of care, I think it's very, very important that we have to select the patients very carefully, do a good quality MRI scan, ask your radiologists to get trained into whether it's T3A, B, C, D, and also correlate it with pathology. That is very, very important, whether patient has a tumor deposit or extramural vascular invasion. All of these are really important criteria which will help you select your patients for total neoadjuvant therapy. TNT does not improve survival, one must remember that, which is what really matters to our patients, living longer and having a better quality of life. And actually, there is not enough data to show that it improves sphincter preservation as well, other than in select group of patients. This study was very exciting. Phase 2 induction PD-1 blockade in patients with locally advanced MMR deficient rectal cancers done at Sloan Kettering. And for stage 2 and 3 mismatch repair deficient rectal cancers. And the thing that was exciting about this study was that all the patients had a complete response. And what was notable in this study was that they did biopsies, sigmoidoscopy, MRI, clinical exam, and a PET scan for all of these patients who were followed up very, very closely. Doing biopsies, I think I would not recommend doing that, because we know that after radiation, you don't know whether it's, because we know that the response can continue for 11 weeks, 7 weeks later as well. So, but other than that, taking pictures on sigmoidoscopy, all of these actually will help you in helping your patients follow the watch and wait strategy. So I think this is great because unprecedented 100% response rate. None of these patients had surgery, chemo, and radiation. So if you're able to avoid that in a select group of our patients, why not? Financial toxicity is huge. One dose of dostarlimab is about 18 lakhs. And also we don't know how long to give it, what the schedule is, when should we stop it. So the pros are it improves disease-free survival, higher pathological CR rate, which possibly will lead to organ preservation and watch and wait for quite a few of our patients. No impact on survival. And also the studies show that short-course radiotherapy is as good as long-course radiotherapy and should be an option which should be offered to our patients. And also it allows for potential de-escalation of treatment. ctDNA, I think, should not be offered as a routine, but should be done in a clinical trial to see whether you can avoid adjuvant treatment in a select group of these patients. Pancreas cancer, as you can see, the survival has improved over the last few decades. There have been incremental small improvement, and it has been mainly because of cytotoxic chemotherapy, FOLFIRINOX, gemcitabine, nab-paclitaxel, rather than any targeted treatment. There's only one slide I have for pancreatic cancer. I think it's very important that we do germline BRCA testing in all patients with early, advanced, or patients with stage 4 pancreatic cancer, because it not only guides the family, but also helps in having a treatment option which is available for the patient as maintenance treatment. And like I said earlier as well, one of my first patients who had a pathological complete response with pancreatic cancer was somebody who had a germline BRCA mutation and received gemcitabine cisplatin. So cisplatin is something which is very cost effective for our patients and easily available. And in second and third line testing, I think we should not discount KRAS, because with KRAS wild, there are a lot of options like NTRK, HER2, BRAF, ALK, all of these become available. And it's very important to know that you do have compassionate use access programs for some of these. So I think this is something we should try and do for our patients. One of my colleagues, Dr. Patel, is actually creating a dashboard where he would have which program is available for which mutation. So I think all of us in India can then have access to that. Very briefly, Dr. Jagannath just did a wonderful MDT on neuroendocrine tumors. I just wanted to show one slide that patients who had previously received lutetium dotatate, this amazing, fantastic study from All India Institute, Delhi, they used actinium dotatate in JEPNETs, and as you can see, the overall response rate in patients who progressed on lutetium dotatate was about 46% with a disease control rate of 71%, which I think is very exciting. This was presented at an international meeting. It's very important that in India we generate our own data and also talk more about it. Gallbladder cancers, again, we are all very passionate about this. It's a common cancer for us. The TOPAZ study, again, as happens with all the Western studies, biliary tract cancer, they lump it together with all the cholangiocarcinomas. 25% patients in this study had gallbladder cancer. We know gemcitabine cisplatin is standard of care as per the ABCO2 for stage 4 patients with biliary tract/gallbladder cancer. So this trial compared the standard to addition of checkpoint inhibitor and showed that there is a survival benefit. And the subgroup analysis showed that there is a benefit in gallbladder cancer patients as well, as you can see at the bottom on the far end. But the benefit is slightly less. And we know that gallbladder cancer patients do behave differently compared to cholangiocarcinoma. Stomach cancer, again, this is a very fantastic, even though it's this data was analyzed retrospectively, but all of the patients in this individual patient data meta-analysis were on clinical trials like MAGIC, Classic, ARTIST, and ITAC-S trials. The data was pooled together, and they looked at MSI high patients. Again, this is very important for us in India because as you can see that patients who had MSI high and had surgery alone, their survival is fantastic. So I think we need to start thinking whether we can avoid any sort of chemotherapy for these patients. So in India, I think we can collect the data for MSI high patients. We have a lot of patients, I would say 30 to 40% of our patients who do not get adjuvant therapy, to see whether they are MSI high and whether their survival is better. So I think this will be probably practice changing down the line. If I have a patient who's MSI high and who's borderline PS, I actually feel quite comfortable in avoiding adjuvant or neoadjuvant therapy. Very briefly, we know that FLOT is better than ECF. I won't go into the details, but CROSS is not, and so I think FLOT is the standard of care for us. In advanced setting, very important biomarker-driven treatment, HER2 positive, 5-FU platinum-based, trastuzumab, pembrolizumab addition has shown a progression-free survival benefit, but at least as per the TOGA trial, we should consider adding trastuzumab. For HER2 negative patients, if CPS score for PDL1 status is important, and it depends what the score is. I'll just talk about that a little bit, and what the score is and what drug you're going to use. If you want to take the cutoff as 5, the trials suggest nivolumab. For pembrolizumab, the cutoff is 10. And again, second line and third line. So PDL1 assessment actually has not been optimized, and I think it's very important that before we start the patient on a very expensive drug, that we make sure that the test is done properly, and there is a lot of lack of concordance between the assays. Just pick up the phone and ask a colleague as well. That's another thing which is very important, I would suggest. ctDNA, we are doing it quite routinely without robust evidence. I think it is important where in some patients where the tumor is negative for HER2, we have a drug, trastuzumab, which is a biosimilar and is available in India. So this is one setting where one can do ctDNA because there is some evidence to show that it may be present in liquid biopsy, and then it gives us a target to improve the overall survival for our patients. For GISTs, again, there are patient compassionate use programs available for some of these drugs. So important to think about this if you get a patient of GIST, especially if they have a wild type KIT mutation. Esophagus cancer in patients with adjuvant immunotherapy is something which is being discussed, and patients who have after chemoradiation, if they have residual disease, this is something we can think about in some of our patients, irrespective of the PDL1 status. In hepatocellular carcinomas, what's new is our first line is atezolizumab, bevacizumab, but I would say 98% or 99% of my patients, I end up using lenvatinib, which is a very safe drug, and there are enough cost-effective and efficacy data analysis to show that that is also the right option. For metastatic patients with colorectal cancer, I think it's very important that we define the liver-limited disease, because we know that there are a group of patients. This slide I borrowed from Professor Adam, and you can see that, you can have conversion therapy where unresectable may become resectable. So very important in an MDT to define the liver-limited disease and possibly think about curative intent in those patients, because if you look at various scores, the 5-year survival for some of these patients can be as high as 40%. So current trends in GI and HPB is, I think if we want to do the best for our patients, finding the target is very important, and there are some targets against which we have drugs and biosimilars available, which are not too expensive. If there is a trend in GI oncology, we stopped that in breast actually. We know that sequential treatment is better than combination, but in GI, I think we're going that if 2 drugs are better, 3 would be even better. For biliary tract cancer, the GAP study combined GemCis, NAB, paclitaxel. Ideally, what one should do is GemCis should be first line, second line could be folfiri or capecitabine irinotecan, third line could be NAB, paclitaxel, or even second line, and then you may have other targets based on MSI, tumor mutational burden. So I think we need to really rethink before we start adding drugs, and also, of course, immunotherapy is added to every single chemo regimen in all the cancers. The robotic surgery, proton therapy, HIPEC, PIPEC, I think in revenue-driven models, these are being done routinely. I think it's very important that you create a registry and generate evidence for the use of this, even if it is retrospective. The real world evidence is very, very important in trying to justify this, rather than using this, as we just heard, with these modalities, which actually in some may not be so helpful for our patients. De-escalation of care is important. I haven't delved too much into it, but duration of adjuvant chemo, giving more than 3 months of oxaliplatin, we know is pointless. So we should not give more than 3 months of oxaliplatin-based chemotherapy. If you need to give it for 6 months, then one can continue capecitabine or infusional 5-FU, especially in those patients who are very high risk, and whether we should think about whether we can avoid chemo in a certain group of patients. Thank you.